Good afternoon, and welcome to today's Lunch and Learn webinar for the Iowa Pediatric Mental Health Collaborative, From Struggle to Strength, a comprehensive approach to treating chronic pain in children and adolescents, presented by Dr. Anureet Walia. My name is Kathy Dixon, and I'll be moderating the session today. I'll cover a few housekeeping announcements before we get started. The webinar will be recorded and made available for viewing on our YouTube channel. The link will be shared in the follow-up email after the session. Following the presentation, we'll have time for questions. So please put your questions in the Q&A feature in the webinar toolbar, and we'll cover as many questions as time allows. Instructions for how to claim credit will be uploaded to the chat section, and I'll also send that in the follow-up email after the session. So without further delay, it's my pleasure to introduce our presenter today, Dr. Anureet Walia. Dr. Walia is an associate professor at the University of Iowa Carver College of Medicine and shares a joint appointment with the departments of Anesthesia, Psychiatry, and Pediatrics. She is board certified in psychiatry, child and adolescent psychiatry, and interventional pain medicine. Her primary academic interest is treating chronic pain in the pediatric population and is the founder and director of the Pediatric Comprehensive Pain Clinic, where she combines use of her unique board certifications in child and adolescent psychiatry and pain medicine. Besides that, she also provides clinical services in the child and adolescent psychiatry inpatient unit and the adult chronic pain clinic. She strongly believes that pain control is best achieved by using a combination of therapies, the multimodal approach, and tries to use that the best in treating her patients. So welcome, Dr. Walia. I'll turn it over to you.
Thank you so much, Kathy. Okay, so we are going to start talking about today regarding chronic pain in children and how we can best approach and treat it. So a very good afternoon to everyone. I do not have any disclosures here, no financial or commercial interests or relationships. And the objectives of today's talk, which were, I guess, presented to everybody, is to talk about the epidemiology of chronic pain in pediatric population. What is the importance of treating that? And then how do we actually approach and treat it by using the biopsychosocial model and the multimodal treatment modalities? Okay, so before we go any further into the details of the topic, let's talk about what is pain. I am sure, like a lot of you probably are familiar or might have come across this definition of pain by the International Association of Study of Pain, which was last modified in 2020, where they describe pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So something of importance here is that it involves everything from a sensory, emotional, and maybe a physical experience as well. So that physical experience or the tissue damage comes as a maybe, but everything else probably is actually true in there, right? Now, there is another one here. This is not a formal definition. It can be treated as a code and, whatever. So the Spain nurse, Margot McCaffrey, in 1999 stated in her words that pain is whatever the experiencing person says it is, existing whenever they say it does. And actually, I feel that there's a lot of truth and weight to this, because in the end, when our patients walk into our clinics and they claim that they have pain, just because the lack of objectivity, we actually truly need to believe in them and treat whatever they are saying is making them uncomfortable. Sometimes you can prove it, the other times you cannot. So that makes it really, really difficult. And let me tell you, not just from a patient standpoint, but a physician standpoint as well, or a provider standpoint, I should say. So it is something that is complicated at both ends. Now, moving on from there, what is the importance of treating pain in children? So, pain, kind of we all know, is what is the essence, or what is the purpose of pain? So pain is a warning signal that something is wrong, right? So it should be a good thing. So why would that be a problem? The problem lies because pain not just causes a patient to feel uncomfortable, but it also causes changes in all of the different body systems, including the pulmonary, the cardiovascular, the endocrine system. It affects the immunity. There is a change in the coagulation profile. The GI system is affected, and of course, musculoskeletal, function, fatigue, and immobility that comes with it. So, looking at all of what it does as a consequence of untreated pain in all of these systems, there is a need to actually treat it, right? So, when somebody is complaining, you need to kind of focus and pay attention to it and treat it. Now, specifically in children, there is a mounting data to show that untreated or poorly treated pain in children has lasting negative effects. And it is not just related to the physiological changes that it brings to the body, but just from the aspect of the emotional, impact of that, where the memories for pain and the amount of distress experienced in early life kind of shapes the response in future events. There is an avoidance that comes with it because of the specific or generalized, fear related to what the children have experienced. This leads on to higher risk for morbidity and mortality with the avoidance of preventative or maintenance of care. And there is data which states that increased analgesic and anxiolytic requirements in future procedures for children who have had pain early on in their life. Now, children with persistent pain suffer more physical symptoms in adult life, more anxiety, more depression, and inadequate analgesia for initial procedures in children diminishes effect of adequate analgesia in subsequent procedures. And there have been data that lower morphine doses leads on to higher post-traumatic stress disorder in months after the major trauma. So what that means is that untreated chronic pain in children incurs a high risk for the subsequent development of pain and psychological disorders later in life. Now, it has taken quite a few years for us to, come up to realizing the importance of one, treating pain, and second of all, treating pain in children. Because for a very long time, people have lived with these erroneous assumptions that have hampered the efforts to assess and manage pain effectively in children. So some of the myths that people have believed in over time is that incomplete myelination of nerve fibers precludes the transmission of pain impulses. Young children are unable to sense pain neurologically. Children do not interpret noxious stimulus as pain. And children do not experience the deleterious consequences of severe pain in the same way as adults. But research on animal models and clinical research in children has challenged these myths. And one of the papers, it's pretty iconic that I'm going to mention in here is Taddeo and colleagues added to their provocative and fascinating findings that newborns circumcised without anesthesia when compared to those circumcised with, a eutectic mixture of local anesthetics, or when compared to the uncircumcised neonates, showed more intense and prolonged behavioral responses to the pain of immunizations at 4 to 6 months of age. So definitely that exposure, or iatrogenic or otherwise exposure to pain, affects the pain response of children later in life. Now, more to clarify these myths, if we go to the developmental and the behavioral, some of the differences. So if we look at this developmental, pain processing of how it happens, so we can see here that the myelination begins at like 22 weeks of gestation, and 37 weeks, the myelination of nociceptive pathways to cortex is complete. And so even if, children born before term or the myelinated fibers are not myelinated, but it does occur during the early months of infancy in them as well. But another thing to notice here is that incomplete myelination does not alter the pain perception, because lack of myelination merely implies slow conduction of pain. So myelination helps with faster conduction of nerve impulses. While if we actually compare to the distance that any kind of transmission has to travel in a small neonate infant child is way lesser than an adult. So it kind of counteracts, even if the myelination is not complete, it still would. So this is something that even preterm neonate will experience pain pretty similar to a term infant there. Now, more things for understanding the developmental sequence of child's understanding of pain. So now we know that every child, kind of baby or older, experiences pain, but the understanding of that is different, and this is based off of the Piaget's psychological model. And according to this, the 0 to 3 months, there is no apparent understanding of pain, but the prototypical sensory and emotional perceptual awareness is still there. Memory for pain is also available shortly after birth. By 3 to 6 months, there is immediate pain response of infancy, which is supplemented by increased emotional differentiation. So that is why the kind of like the objective measures that we are using to identify if patient is in pain or not, that is more so based on their emotional response of like crying and limb withdrawal and stuff that we use to actually identify that. 6 to 18 months, children develop clear fear of pain situation. They try to describe the pain in their own words, like an ouch, owie. And then there is somatic localization, so they can pinpoint to where it is actually hurting them. Up to about 6 years, there is still a little pre-logical thinking, which is kind of characterized by more concrete understanding. There is, kind of like the meaningful description of pain in language is there, like hurt, pain, but there is still that magical, thing related to it that you can actually tell the kids that, if something hurts, like a chair hurt them or something, and you would just hurt the chair. It's like, oh, okay. So those kinds of things, or the owie just went away, or, there's still a little bit of like a magical thinking involved with it. While 7 to 10 years, there is more concrete operational thinking characterized by child being able to distinguish self from the environment. They have the capacity for behavioral coping strategies. So you can use hypnosis, relaxation, imagery. So this is important to know, because if you are trying to imply treatment, psychology treatment is more so helpful, like when the kids, like, CBT and relaxation stuff, when they have that understanding. 11 plus years is more formal logical thinking. They characterize by abstract thinking, introspection, increased use of coping skills. So pretty much like how an older, adolescent or adult would be responding to that. So this is important for both for the assessment and the treatment as well. Now, the pain perception can also have a behavioral component, and this is driven more by the fear avoidance model. So there is increased expression of pain due to fear. And then the patient's past experiences of pain, which is like frequent exposure, increases the sensitivity to pain. And then it is not just your own experiences, but the experiences of people around you. So families' reactions, like minimal attention for pain behavior, kids learn to cope with pain. While if there is excessive attention, they learn to express pain more, and there is more of like attention-seeking behavior that can be related to that. So all of that is important when you're treating, because you're not just treating the child, but you are involving the family in there too, and how they need to react to the child hurting actually governs a lot of like how it's gonna go from there. Okay, so moving on from here, we talk about the biopsychosocial model. Now, we have heard this term of biopsychosocial model in, psychiatry, but it is something that is important for a lot of other, medical conditions, including pain as well. So pain has a big, for long, it was dichotomized, but we have realized over time that all of these factors, the biological, psychological, and the social, all of these factors interact to exacerbate and maintain the pain. And so we cannot just look at one aspect of it. We need to look at the whole person and treat them as one and not just merely kind of like as a body part. So as mentioned here in the slide, in the biological, it is more about the nociception, which is driven by genetics, sex, age, physical health, any kind of like comorbid medical condition. From a psychological aspect, of course, the stress around you, any history of mental health disorders, specifically anxiety and depression, any comorbid neurodevelopmental disorders like autism, any history of trauma, personality disorders and types. And all of them actually drive the individual beliefs, self-esteem, how the patient's expectations are, what their pain behaviors are. Catastrophizing, this is something that we study quite a bit in chronic pain and psychology, and then how they would cope with pain. So all of that is driven by the psychological aspect. And then from a social aspect, your family, your peers, your school, work environment, socioeconomic status, that builds the interpersonal relationships, the patient's identity, cultural beliefs play a big role. And then also what kind of like support network you have and the pain accommodations that are needed all derive the social aspect of, the presence of chronic pain or how it actually presents. Now, here, I would also like to kind of use this biopsychosocial elements into talking about something what I refer and talk to my patients as a pain dial. So in our brain and spinal cord, we have an adjustable pain dial, and it's somewhat in our control, directly or indirectly, to dial that it up or dial it down. And how we can actually do that. And this is something that, the patients really appreciate and understand when we actually try to show them this here. So there are some things that we do or are happening around us or in our environment, which actually dial the pain volume up. So being sedentary, muscle overuse, crappy sleep, high stress, anxiety, sad mood, any conflict going on, isolation, hopelessness, toxic relationships, all of them, kind of dial the volume up. And how you can actually bring it down is by movement, having social connection, being in a low stress environment, using relaxation, quality sleep, nature, sunlight, positive emotions, hopefulness, having healthy relationships, and being involved in pleasurable activities. So all of these biopsychosocial factors like sleep, emotion, trauma, genetics, they can kind of adjust the pain volume. And this is, kind of like a few examples of like how you can do that. And sometimes when you explain the patients like this, they do understand it and will actually be more willing to engage into some of these modalities, which can help decrease their pain. Okay, so some of the common pediatric pain conditions that we see in our, pain clinic. This list is, of course, not like a complete list. We see things outside of that, but I've tried to kind of compile some of them. So low back pain, headaches, abdominal pain, musculoskeletal pain, any kind of like nerve-related pain, CRPS or complex regional pain syndrome. We see a big population of kids with hypermobility or, a diagnosis of Ehlers-Danlos syndrome, juvenile idiopathic arthritis, TMD or temporomandibular joint diseases, chest pain, pain secondary to general medical condition, cancer pain, sickle cell disorders, any kind of like somatic symptom disorders, or actually functional neurological disorders, pelvic pain, cerebral palsy or spasticity, metabolic disorders, and some neurodegenerative disorders. Now, all of them have some kind of like a shared biological and clinical feature. So, of course, there can be a shared biological mechanism, but even if we go by the clinical features, there's a big female preponderance. There is usually a family history. There is a history of psychosocial trauma. Certain personality types and mental health disorders have a high predisposition. Autonomic dysregulation, we see a lot of patients with either orthostatic intolerance or having a postural orthostatic tachycardia syndrome diagnosis, hypermobility, as I said, sleep disturbance, impact on social, school, family life. That's kind of like pretty commonly clinical feature that we see amongst all of these patients. Now, using all of that, how do we approach these patients and how do we treat them in our clinic? Is we use the multimodal treatment approach. So that involves pharmacotherapy, procedural interventions, integrative medicine modalities, physical therapy, psychotherapy, some lifestyle modifications, work reintegration, treatment of comorbidities, skills training, and I'm going to talk about all of these in detail from here. But I think before that, I do have a couple of things I want to mention before we actually go into the treatment plan. That one, our chronic pain patients, when they come to our clinic, before that, they have cried for help and begged to be listened to. Most of these patients are coming in with the ideology that they feel that their voices were muted, ignored in encounters with medical professionals. Patients stated that physicians don't seem to get it, and patients thought that they were lying, they were making it up. Patients always want their questions to be answered, and they want clear communication, and they want their healthcare provider to be trustworthy and honest. So a very big thing in treatment or in approaching these patients is there is a value of listening. And, as I said, it is not uncommon that, they go through numerous investigations. They go through seeing numerous physicians. We are not the first people that they're coming to with chronic pain. They've already gone to many different providers. And then, the first thing that they are kind of thinking of is that, will they believe in me? Will they trust my pain? Will they actually trust what I am saying? Or are they just going to say it's all in my head? And, these are the actual quoted words of, the patients that I have seen. So it is important that you kind of listen, understand the child, and in order to kind of create a child-centered focus, and of course involving the family into it, but it has to be very, very patient-centered and patient focused. So in doing so, we have we kind of focus on the functional indicators of improvement. We are trying our level best to get them to normalizing their life and making them a part of their treatment. So sometimes even trying to ask questions about, yes, pain is important, but what is the pain impacting? What is the pain affecting in their life? What are the things that they are usually interested in? What are their hobbies? What do they enjoy doing? And how has pain impacted that? Are they able to do X, Y, and Z, whatever they talk about? So we need to try to focus on normalizing those things. And in doing so, we will, of course, treat their pain. but the focus is sometimes not to bring the pain down to a zero, but bring their life back to normal. And it can backfire when you actually use these words and sometimes tell the patients, because they are coming in with the ideology that they want their pain to come down to a zero. But it is difficult. And I always tell my patients that zero can mean very different to you than what it can mean to me. So, sometimes, and pain is very nebulous. It's not something that I can objectify and I can say that, okay, this is how it is. And I don't have a magic wand. But yes, I can work with you and I can try to bring you back to a normal life and a functional way in the society that that you will be happy. And yes, in doing that, if we can bring the pain down to a zero, of course, it's a win-win kind of situation. So not trying to make the whole multimodal thing as like a boring lecture, I'm going to try to explain it with an analogy that one of the analogies, actually, I should say, that I use it with my patients to explain it to them. And I call that the cupcake analogy. I always give credit here because one of my colleagues, she's a PharmD, Lee Crawl, she kind of presented this idea once to me, and that's how I have been using it, actually sometimes using it for not just for my patients, but actually for teaching people on the multidisciplinary pain management as well. So, what I try to tell my patients is that it is very important to build a very customized cupcake for them, and how it involves the different parts of the comprehensive treatment plan. Okay, so let's go and build this custom cupcake for our patients. So first of all, the very important thing for our cupcake, or the key element, is the cake. And what comprises the cake in our comprehensive management is functional restoration and rehab therapy. So the focus of chronic pain management is to improve function. And I kind of touched on that even in the previous slide, right? We need to understand that function improves before pain. Physical activity and sensory input, they normalize the pain signal. And it is kind of counterintuitive because typically pain makes us rest. So this approach requires a lot of support from an interdisciplinary team. And we need to make our patients understand that first your life gets back to normal and then your pain decreases. And unfortunately, it is not the other way around. And it is something that is probably the most difficult part to explain. And how do we actually do that? We take our help from our physical therapy and rehab therapists. And physical therapy and exercise is the key modality. I actually tell my patients that everything else that I'm going to talk about, or everything else that I'm going to offer besides that, we do as part of the treatment to allow the patients to participate in rehab therapy. So rehab therapy is actually one of the most important aspects when it comes to treatment of chronic pain. The physical therapists actually develop their own individualized treatment plan that is based off of each patient's functional goals and, of course, limitations. And we don't play a role in there. Like in my clinic, it's a multidisciplinary clinic. We do have a physical therapist with us. So they are the ones who and then we, of course, we have patients coming in from all different parts of the state and some actually outside the states. So we don't have the capacity to see everybody as a follow-up. So we always kind of try to find places which are the best for, their treatment and try to give them some recommendations, and they can take it to any place that is closer to home and seek this treatment. Okay, the second part of our cupcake is the frosting. And the frosting comprises the pharmacological treatment options or pharmacotherapy. Now, when it comes to pharmacotherapy in children, less is more, none if appropriate, right? But a lot of times we get to a point where we do have to use it. There are some limitations, like, there's lack of pediatric studies, lack of FDA approvals. We use it outside of the FDA recommendations, most of our medications. Most of it is extrapolation from the adult literature and by best judgment, expert consensus, and all that stuff. But pretty much anything and everything that you use in adults, you can use in kids, almost all of them. Now in pharmacotherapy, of course, it's analgesics. We try to stick to Tylenol, NSAIDs, maybe aspirin, COX-2 inhibitors. Opioids are very, very less, mostly for acute perioperative pain concerns. I would not prescribe it for chronic pain. Most of the times it is only like if it's cancer related or something, more of palliative concerns. But besides that, we try to just stick to the non-opioid treatment regimen. There are a lot of adjuncts, like antidepressants, the tricyclic antidepressants, or SNRIs or SSRIs. SSRIs are more adjunct treatments. SNRIs, which is the selective serotonin and norepinephrine, reuptake inhibitors, they are the ones which are more, valuable when it comes to chronic pain treatment. Anticonvulsants like gabapentin, pregabalin, carbamazepine, oxcarbazepine, topiramate, lamotrigine, divalproex, and zonisamide, all of them, they have different, they work on different receptors and are used for different kinds of nerve-related pain. Clonidine, NMDA antagonists, other psychotropics like neuroleptics and stimulants. Muscle relaxers, more as needed treatment. There are a lot of topical preparations like lidocaine, steroid, diclofenac, capsaicin, clonidine patch. There's a lot of compounded mixtures and stuff that can also be used. So these are just examples. Not all of them are something that, we would use in everybody, but these are some of the choices that we can actually choose from. The next part of our cupcake is the filling, right? Everybody loves Molly's cupcakes here. So filling is not always necessary, but it does add an interesting component to our cupcake. And the filling in our case is procedural interventions. The procedural interventions are always in context with multidisciplinary therapies. There is low gain as a solo modality. People kind of ask me, what interventions would you perform in kids? And pretty much anything and everything that we would perform in adults for appropriate indications, of course. In kids, it's not done more for degenerative issues. It is for pain concerns, but anything and everything that you can think of, except maybe permanent implants, we won't. But besides that, you can do everything. Now, the procedural interventions, they are performed, either for diagnostic purposes, for surgical planning, or for therapeutic purposes, where we have multiple options. Most of our procedures are kind of either neuraxial or peripheral nerve blocks. They can be performed either with fluoroscopic guidance or ultrasound guidance. There are some advanced procedures as well, like neuromodulation, intrathecal pump, and all of that. So that is something sometimes not as commonly done in children. But the list is endless. But the thing to remember is that, as I said, always in the context of multidisciplinary treatment and assisting them to participate in restorative therapies and be able to function better in life. Now, procedural interventions do help reducing, central sensitization. They provide the regional pain relief. They also decrease the systemic analgesic requirements sometimes and facilitate the successful participation in rehabilitative program. So if performing one procedure can get the kid back into sports and school faster because they are able to participate in rehab therapy, I think it's kind of like a win situation, as long as it doesn't have any side effects to it. These are some of the, common procedures that we do. I won't go into the details of the slide, but, it involves, as I said, the peripheral nerve blocks, neuraxial procedures. You can do joint injections. There are sympathetic blocks. There's IV regional anesthesias, botulinum toxin injections, trigger point injections, neuromodulation, radiofrequency denervation, and there's more to it as well. Now, this is one paper that I like to kind of mention here, which emphasizes the use of interventional procedures that was associated with return to normal function, reduction in pain intensity, and reduction in pain medications in almost 3/4 of patients included in the multidisciplinary pain treatment program. And the history of psychiatric disease was associated with failure to respond to interventional procedures, which actually also tells us that this is not just the sole modality that can be helpful. So if somebody has psychiatric disease, their psychological influence is way bigger on their pain. So that needs to be treated first. So there's no one protocol or a treatment. It's like a big thing. Lots of things are available, and not every block or part fits into everybody. You have to just customize it accordingly. So not everybody loves filling in their cupcakes. Maybe I should say that. Okay, so the next component is flavor, of course. Flavor is something that is really, really important. And the flavor here is psychology or psychological therapies. Now, to understand this, we need to understand how stress affects pain. So both physical and psychological dysfunction in chronic pain is kind of modulated and upregulated by fear of pain, leading to the fear avoidance cycle. Diminishing the fear of pain strongly correlates with positive functional outcomes in children with primary pain disorders. And further, there is a robust positive association between pain-related fear and disability. Now, pain-related fear may be an important therapeutic target for approaches aimed at reducing pain-related disability. So if you look at this chronic pain cycle, the pain leads on to anxiety. That pain is signaling tissue damage and harm. Now, brain becomes more focused on the problem, and then changes take place in the nervous system, which leads on to more pain. More anxiety leads on to less movement, and that leads on to more changes in the nervous system and the musculoskeletal system, which exacerbates pain as well. So this is kind of like a vicious cycle that starts, and it needs to be broken down somewhere. Yes, we are doing rehab therapy for the muscular portion, but until and unless we get that fear of movement out, we cannot, go through the whole, kind of win this. So psychology helps with breaking that fear avoidance model. Now, some of the other things that are there in psychology are, of course, here again, there is a depiction of the fear avoidance model here. So there's brain catastrophizing that we target. Now, another thing that I always explain my patients is the autonomic nervous system response, or how autonomic nervous system is kind of interrelated, both from a physical aspect of pain and from a psychological aspect. So we all know that we have a sympathetic and a parasympathetic nervous system. There is a sympathetic nervous system, which kind of rules the fight or flight response. That is something that if something is wrong, that is the system that is, activated. And the idea is that you're running away from the system. So if a tiger is chasing you, you really need the sympathetic system to be activated because you want to run away from the tiger. But think about it, if your body is in constant high sympathetic state, it's in a constant state of a tiger, a bear, or whatever, like chasing you all the time, that is not going to work, because you're in that heightened response all the time. Now, we need our parasympathetic response, which is more of a rest and digest state. And that is what we try to activate with all of the different psychological modalities of like mindfulness, relaxation, where we are calming the sympathetic system down and reactivating the parasympathetic response and kind of bringing our body to a balance. Now, besides that, it is also important to understand that anxiety, depression, and behavioral disorders, they are the early risk factors of chronic pain, and it's not usually vice versa. At lower levels of anxiety, higher pain is predictive of greater disability. However, highly anxious adolescents tend to function poorly regardless of the level of pain. So therapy can help to, restructure the negative thoughts, teach relaxation skills to help calm down, the nervous system here. And, teaching active coping skills like builds self-efficacy and reduces the passive victim mindset. And there are various different kinds of therapeutic modalities. We use cognitive behavioral therapy. We use acceptance and commitment therapy. There's a lot about, there are a lot of different other modalities that you can use, like biofeedback and all of that as well, because that sometimes is very helpful because it does have some sort of like objective quality to it, and adolescents sometimes are more accepting of that treatment as well. But we do have a psychologist on our team here as well who sees all of the patient evals, and we offer that or something locally for them. And then we also share a lot of online and physical resources that the patients can use too. Now, what makes our cupcakes look pretty, beautiful, enticing is decorations, or here, sprinkles. So what are sprinkles? Sprinkles here is pain education. Now, pain education holds a great importance in demystifying the problem. Even just educating the patients or letting them believe that we know that the pain is real, but it has lost its warning function. And helping them understand that we do understand that, is you can kind of win the battle right there. Now, just explaining what is causing it and why a certain treatment modality is helpful helps with patients' responsiveness to the patients are more responsive to the treatment. So it kind of predicts the patient responsiveness to intervention and reduction in pain score. Now, repeated and overlapping education is very beneficial from different members of the team. So hearing the similar kinds of things from the perspective of a physician, a physical therapist, and a psychologist helps them understand why the certain modalities that we are recommending them, how they are important, and how they can be helpful. So sometimes we get upset that the patients are not understanding and not doing what we are asking them to do, but actually we are never even trying to explain why is this something that is important. Because sometimes to people, this actually telling them that how psychology, you need to go to a psychologist for treatment of chronic pain can make them just feel that this person thinks that, oh, it is not real, that's why they're asking me. But if you actually explain them that how it is interrelated and how it plays a role, they might be able to, you can have that engagement better. And the same goes for physical therapy or even a procedural intervention or a pharmacotherapy treatment. So pain education overall is very, very important. So now that our cupcake is ready, we need to make sure that our patients have the right access to the cupcake. It is important for us to assess for barriers that may prevent individuals from successfully implementing recommendations from the team or other concrete needs, basically. So therefore, we have to collaborate between internal and external providers, accommodations for and planning for success at home and work, healthy lifestyle routine and development, and supporting how we can support that. Assessing for other needs like, local resource finding, or maybe even transportation, insurance, financial, working with, in our case, like with children, working with schools. Sometimes, children need some kind of like accommodations. We try not to have them, miss school, or, we want them to engage to as normal a school life as possible. But in doing so, sometimes it might be as simple as them needing an elevator pass, sometimes them a visit to a nurse like one time a day or something, or taking breaks in between, or even sometimes some modified schedules like, yes, PE is important, but that kid might not be able to do heavy lifting in PE, but they can still do other things in physical education, which is important, rather than them just completely sitting out and not going to school. So these are just a few examples of that. Now, every patient is different, and every patient's chronic pain journey is different, and therefore their treatment is different. So I think everyone likes a different kind of cupcake, and everybody deserves a different kind of cupcake too. So that is how it is. And so it is something that these are the modalities that are available. How do we customize it for a patient, and how do we make it a patient-centered focus of it is something that is important, and that's where our role is. Now, there are some golden rules of chronic pain. All pain is real. Improvement is first measured by increased functioning. Exercise is good for sleep and chronic pain. Sleep is very important. Reduce the anxiety, because anxiety plays a big role. And then it is a long-term problem, and it requires a long-term solution. Just doing something for a very short term might not give you the results, or maybe, it might come back. So that is it from my side. So thank you so much for listening. I will just open it for questions.
Thank you so much, Dr. Walia, for excellent presentation. So we'll now take time for questions. Please put your question in the Q&A, and we'll get started. So we'll start with a couple of questions that we had that came in through registration. And one of those was, what are recommendations for school to healthcare provider communication? And I know you touched on that when you were talking about kind of the reintegration with school, within school settings.
Right. I think one of the big things is that there needs to be effective communication, like between schools and healthcare providers. And it's kind of crucial in managing chronic pain. We see that quite a lot. I think we do school letters a lot of times. Now, one of the big things that I make clear to the patients and to the school is that our idea is not to get the kid out of the school. My idea is not to get the kid out of PE, because we are advocating for movement. Like, we are asking them to move. We are asking them to do things. We are asking them to be a normal teenager or whatever their age is, right? So, but in doing so, sometimes, there is a spectrum of people that come over to us. And a lot of times those kids are who just haven't gone to school for months, or just are able to only attend 2 days a week or something. So my idea is that I want them to get back into school like every day. Sometimes we start off with just 2 hours a day, 3 hours a day, 4 hours a day, and then eventually to a full day of school. But we kind of try to work with them with clear communication, sometimes help them develop IEPs and 504 plans if needed. There can be, ways like if patients sign release of information, that the school can actually contact us and we can talk to the school nurse as well. But a lot of times parents are a medium, that's how we do. And, depending on how much they want to share. And I think that it will be helpful if, there is some training of school staff, if I can, kind of talk something to the schools about this, and they are more aware of it. I think it will be more helpful that way, but that is something that I guess we are lacking at this point of time. The other thing is encouraging self-advocacy. And as I said, we get a spectrum of people. We get a lot of the kids on our, who probably want to do everything and don't want them to be seen as somebody different. So they don't even use those accommodations. So we kind of help them understand that it's okay to seek help. It's okay to advocate for yourself. So it goes, in a lot of different ways.
Okay, thank you. How do you approach children, including their family and treatment team, presenting with chronic pain and suspected comorbid functional neurological symptom disorder, aka conversion disorder? And then what aspects of your assessment, conceptualization, and treatment approach change for this population? What aspects of your assessment? Yeah, okay.
And so I would say that we do have quite a bit of our, I would say population that comes in with FND or functional neurological disorders, which is a big spectrum of like just having conversion disorders. We are now going away from that diagnosis and we use FND all the time. Some people come in with gait instability, some just with pain, some can have like seizure disorders and then having comorbid pain in there. I think it is one population that you need a lot of collaboration with the family, with their maybe outside school and stuff, but more importantly, collaboration with the different medical professionals. So a lot of times we would initiate, some more, referrals to other medical specialties, or sometimes they have already seen those and have everything ruled out. But we want to make sure that any of the symptoms that they are coming in with functional, maybe even if it's a functional GI, like functional abdominal pain is very commonly seen in our clinic, that we want to rule out every organic possibility. And then after that, I think the hard part is, how do you explain to the families? How do you talk to them about it? How do you help them understand of like how their powerful brain is actually driving some of this? And this is done with the help of, psychology with us, and of course me. And then, we seek help from the other, whatever the issues are. We may need help from the GI team or neurology team or whosoever is involved in there. But I think language matters a lot. Validating some of their symptoms matters a lot. And then when we are getting them out of that, making a plan with involving the patient and the family into it also matters, because if we try to give a protocol of this is how things are done, their participation is very difficult. So just involving them into how we are going to get them integrated back into the society, we do it very slowly. And then, of course, physical therapy and, social work and all of that kind of play a role in there too. But F&D in itself, I can present another webinar on.
Yeah. That could be another topic.
Mm-hmm.
Thank you. And the person who asked that says, thank you. Are there resources that would be helpful for providers to share with parents as they are offering education on pain management?
We do have, I wish I could just, share like a website or anything. But I think if people would be interested, maybe Kathy, I can, send it out to you. We do have a lot of like online resources, be it from YouTube and some other places, like videos that we have, patients watch. There's one that is, right on the top of my head, because that's probably the most common one that I tell my patients is, treating chronic pain in understanding your pain in less than 10 minutes and understanding your pain in 5 minutes. This is like a YouTube video. It's from a German, illustrator who uses like cartoons and all that to kind of help patients understand about like, the brain and the spinal cord and every connections and, how biopsychosocial element and everything into it. But I can definitely share the QR codes and resources that we have. Books we have, specifically for psychology, for for the kids, but also for parents and families, of how to understand that and how to go on forth. Nowadays, we are living in the tech world, so there are a lot of apps out there that sometimes, because we live in Iowa, sometimes in some of the towns they don't have all those resources available. So we try to share that with them so that they can at least start off somewhere, and then we can try to find somebody that they can actually see. So I'll be happy to share those with you.
Oh, that would be great. Yeah, I'd be happy to send those along with a follow-up email.
Mm-hmm.
Okay. This is kind of a specific, are there state required reporting of analgesia for pediatric populations?
Yeah, I think, there's some kind of like guidelines or regulations, basically. So hospitals, healthcare providers, they are trying to ensure like safety and well-being of children. So you of course report any adverse occurrences like sedation, analgesia, including which involve pediatric patients. Maybe sometimes hospitals have written policies and procedures of mandatory reporting, but more so in terms of like, of course, like all of us do, child abuse and dependent adult abuse, and in that, if something like this is involved, maybe. But there's not specifically, of course, like if somebody we are treating with opioids, we have that direct reporting of that anyways. We usually don't do that, but we have our opioid contract, like how we do for adults, and everything on there. But adverse events and stuff, probably yes.
Thank you. Do you have some tips on how to explain chronic pain to children in a developmentally appropriate language?
I think that is also something that, challenging. And we are lucky that there are certain books that are written for like kids who are even less than 10 years old to actually understand in their language of like how it can, how their brain and, how their nervous system and everything is kind of interrelated. So one of the very simplest ways of like how we kind of talk about is that pain is a warning sign, as I say, when you hurt, your body is trying to tell you that something is wrong, it needs to be fixed. But, when you have been in pain for so long, your body loses that potential to recognize the signal from a warning bad signal to a good signal. So every kind of like a signal, every kind of like a sensation or an input is treated as a warning sign, and your nervous system is just acting in a very amplified manner. So it is reacting like I need to save myself at any kind of like an input. And that is where chronic pain or central sensitization kind of kicks in, and we need to calm that nervous system down. We need to bring it back to a point where it can actually understand the good signal from a bad signal. And that is where all of this treatment is kind of coming into.
Okay, thank you. What are the more common co-occurring mental health diagnoses you often see with chronic pain in pediatric populations?
Anxiety, depression, very common. PTSD. Even if someone does not have a diagnosis of PTSD, the history of some kind of trauma, and it doesn't have to be a specific kind of trauma. It can be any kind of like adverse childhood experience or, so instability in the household, which can lead on to reactive attachment disorder, but that's not something that we are focusing on, but there are a lot of things that come with it. There is neurodevelopmental association too. We see a lot of kids with autism, a lot of kids with sensory processing issues, having chronic pain concerns. But I think out of everything, anxiety and depression probably kind of will roll over.
Okay, thank you. Okay, well, it looks like we covered our questions and we are approaching 1 o'clock. So I'll close with a couple of announcements. The University of Iowa Carver College of Medicine is jointly accredited to provide continuing education for physicians, nurses, social workers, and physician associates. All other participants will receive a certificate of participation. Attendees are eligible to claim continuing education credit by completing the evaluation and downloading their certificate of participation. And I did upload the instructions to the chat, and I will also send those in the follow-up email. If you have any questions, please feel free to reach out to me. And in closing, I just want to thank you, Dr. Walia, for presenting for our webinar series. That's a great talk. And I hope you all have a great afternoon. Thank you all for joining today.
Thank you so much. Thank you so much. And I will be happy to help out. And, feel free to, kind of send your patients our way. And, if they need, and we have, as I said, a multidisciplinary clinic where we offer all of these facilities all together. And that is probably the best way you can help these patients.
Thank you.
Thank you. Have a good one, everybody.
You too. Thank you.
Thanks.